59 days. The second time was 49. I'm sorry, I said that so wrong. 52 days was the first time, 49 days was the second time. And Dr. Tennant recommended if I ever get it again to try ivermectin. And so, because that's all that valcyclovir did was just take it down those 3 days. And so I got it again, sure enough, the third time, and tried ivermectin, and it lasted for 12 days. And the fourth time I had it, it lasted for 7 days with ivermectin. This time, this is day 5, I think, 6, something like that. So yeah, we hope it doesn't last very long at all.
I can't believe you've had it that many times.
Yeah, that's that reactivation with the immune system. It really, it's no joke.
No, I've had it once. That was enough.
It's really painful, isn't it?
Yes, it is.
I've never
I said I'd rather have a baby 10 times over than
oh man. Oh, I'm so sorry. That's yeah. Anybody that says they'd rather have a baby, then you know that they're really talking serious.
Oh my God.
I'm so glad to be able to speak. I was unable to talk right, and poor Pat was the recipient of and Valerie, the recipient of text messages with me talking, and I'm just rambling and making these long text messages, and I couldn't talk. I couldn't get my words right. It was just really, it has really messed with me cognitively, and I don't like that at all. That's not
Did you
something
get the vaccination, anybody, for the shingles?
I was told because of the reaction that I had to the first 2 times, do not, they said absolutely do not, but that's with just me. When I had chicken pox, I was 14 years old. And so I was a lot older than most people are. And the paramedics told me then, if I ever get shingles, it will be bad. And so they're like, but that's later on in life when you're in your 40s. I was 14, so that was a light year away for me. I thought 40 was going to be forever. But no.
I didn't even have chicken pox and I got shingles, and they said, well, you must have been immune to it when your kids got it and you didn't. Maybe you built up an immunity. And my neurologist said, no, don't get the shingles vaccine because down the road we don't know what it could do to you. This is what first came out.
That's
so I haven't taken it, and I haven't gotten this again.
That's awesome.
I know somebody that got the vaccine and broke out with shingles from head to toe.
Yes. And I end up with this secondary rash. I'm allergic to a lot of things. So when shingles hits, I get this secondary, like an allergic rash that goes with it. And then that lasts for about 24 hours. And then the blisters start to form, and they make the lines and stuff with the little blisters that are very itchy, deeply itchy, and very, very painful. They burn, they itch, and it's like a sharp stab. So yeah, and that pain does not go away when the bumps do. So
no, they don't.
Is it worse than CRPS?
I would equate it. I would say that it's about the same. It's the same type of pain in mind, like the shooting, stabbing. And as far as severity, I would say that it's very close to the CRPS. Yeah.
Oh, I need to get maybe I don't need to get the vaccination. I don't know.
Right. It just depends on how your body, reacts to everything.
I haven't got COVID, knock on wood. I've gotten the vaccinations for those. So
good.
That's good. Definite known problems with the shingles vaccine. I mean, in general.
I'm not quite sure about in general, but they just told me do not, because the reaction that my body had to the virus. So yes. Okay, guys, it's showtime. We're going to go ahead and start. And it looks like we've got Dr. Tennant on board with us. So that is wonderful. Thank you so very much, everyone, for helping. And we'll go ahead and get started. Hi, Dr. Tennant. Thank you. Thank you for joining us for season 6, episode 9 of Doc Talks with Dr. Forrest Tennant and friends. We're glad that you could be here with us tonight, and we've got a full show ahead of us. So Dr. Tennant, please take it away. Thank you.
Very good. No, I'm glad you're all here. We're going to have a very exciting show. We've got a very interesting guest who's got a journey to tell and some help to give. I've got my crew of pharmacy and medical consultants, and we're going to talk about the fraudulent nature of what's called central sensitization and hyperalgesia. And we're going to discuss that a little later also. Education-wise tonight, I want to start off by saying that I've spent a lot of my time recently dealing with people who have really severe deterioration with their adhesive arachnoiditis. And that deterioration gets into their various organs, their whole body, their paralysis. It's really quite sad, and it's the type of progressive disease that was described clear back in the 1800s as the devil's disease. What we are finding in these cases is that essentially all of them have a reactivated Epstein-Barr virus or the autoimmunity from the Epstein-Barr virus, or both. I want to start the show tonight by pointing out a study that is recently out. It's got a big long name. It was in the Journal of Advanced Research, and it's got a big long name: Autoimmune Responses to Myelin-Associated Proteins as Prognostic Biomarkers in Multiple Sclerosis, Associations with Epstein-Barr Virus Reactivation. What's important about this study is that it's a very large one, and it goes into exactly how the reactivated Epstein-Barr virus causes autoimmunity and a chronic disease like multiple sclerosis or adhesive arachnoiditis. Also, I want you to know where this study comes from. It's a collaborative study, and check this out. It comes from university laboratories in these countries: China, Thailand, Iraq, Bulgaria, Korea, and a couple of other European countries, and they use the lab Immunosciences in Los Angeles, where I'm located. It's a little sad that there were no American universities involved in this study, but what you do need to know is that worldwide now, there is the realization that the reactivation of the Epstein-Barr virus causes autoimmunity, and it does so with 2 or 3 different mechanisms. And that's one of our challenges in trying to deal with prevention of the disease getting worse, like arachnoiditis. And but it also tells us what we've got to do to deal with it. I do want to spend a few minutes talking about something that's complex, and you can call it controversial if you want to. And I don't know that it's so controversial as it is that people just don't want to know about it and don't want to hear about it. The whole concept that a parasitic virus like Epstein-Barr can reactivate in the body and cause cancer and serious painful diseases like multiple sclerosis and adhesive arachnoiditis is just not a welcome message in the medical profession or with patients. It's rather sad, as a matter of fact. But what I do want you to know, and which we're going to have to talk about over time, is exactly how this virus works, what it does, how to test for it, and how to treat it. Now, the first thing you have to know is that the virus does its dirty work by 2 mechanisms, one called reactivation and one called autoimmunity. Now, what I want everybody to know about is reactivation here tonight, and understand it very simply what happens. Now, Epstein-Barr virus enters the human body usually before you're age 2, and it becomes a parasite in lymphocytes. Now, these lymphocytes are floating around your body. They're the main immune white blood cell. Now, that virus stays there harmless and parasitic for life unless you have some kind of stress that reactivates it. Now, unfortunately, that reactivation can come from a number of stressful situations. For example, if you have a severe accident, let's say you have a fall, domestic violence, military injury, that's going to get you a reactivated virus. You're also going to reactivate the virus if you get sick. You get an infection like a shingles or like a meningitis or a pneumonia. Now, the other problem we have that we're going to have to face and talk about is that medical procedures will activate the virus, because medical procedures are stress. In other words, that epidural that you got at delivery, or maybe for therapeutic reasons, maybe the surgery you had, maybe even some other kind of a procedure can activate the virus. Now, what happens when we say the virus has reactivated? And this is the concept I want everybody to kind of try to grasp. When it reactivates, what that means is it leaves the lymphocyte and it enters the blood as a live virus. and it starts floating around your system. Now, as it floats around your system, it's going to look for a new home. Now, it likes to settle in what we call soft tissues. It doesn't enter bone or cartilage. It likes to enter soft tissues where there's a lot of collagen or a lot of fibrous matter. And that's things like intervertebral discs or like nerves or like the arachnoid membrane or the glial cell in the brain. And so it likes to enter nerve tissue and soft tissues, a little bit like, tendons, for example, or fascia. So that's where it likes to land. And it will land and then it will start colonizing, as we call it, meaning it's just going to grow in a clump right in that tissue. Now, as it grows in that tissue, it causes inflammation. Inflammation causes tissue destruction. Tissue destruction causes pain and also neurologic dysfunction or impairment. So therefore, if you have adhesive arachnoiditis and your cauda equina is infected with a reactivated virus, your bladder is going to start going, your bowels are going to start going, your legs aren't going to work, your sex organs aren't going to work. You're going to have, and also you're going to have tremendous perfect pain. So this is actually the way it works. Now, so what do you do about it? Well, first off, I know I've beat this drum before, but I'm going to beat it again tonight. In my opinion, if you've got a serious painful disease and it's not, you're not doing well, you're just not getting some recovery. I'm hoping tonight our guest is going to tell us how we get a little recovery maybe. But if you're not getting recovery, you're not doing well, you need to be tested for the Epstein-Barr virus. Now, they have panel tests today, but the doctors don't know what to order. The labs don't know what to test for. And I'm getting people all the time do the test, but they don't get the right ones. Now, the test for reactivation is different than testing for infectious mononucleosis or for antibodies or autoimmunity. They're different tests, and there are two of them. And I'm going to tell you what they are. One is called the early Epstein-Barr nuclear antigen antibody. The term is early. And then there's a second test called the polymer chain reaction DNA test. Now, both these tests tell you whether the virus is in your blood circulating around. Now, I hate to even bring this up. About 70% of the people we test with adhesive arachnoiditis have an active Epstein-Barr virus. Now, what does that mean? That means that virus is going to continue attacking your arachnoid membrane, your glial cells in your brain, and your cauda equina nerve roots. And that you're going to continue to deteriorate unless you can get that reactivated virus under control. Now, I don't have time to go into it tonight, but I do want to tell you that for the first time, we have a printed protocol for Epstein-Barr viral reactivation. It's on our website, and it's somewhat complex, and but it is something printed because we get asked for it all the time. It'll contain some compounds you've probably never heard of, but nevertheless, you have to aggressively try to control Epstein-Barr viral reactivation, and hopefully you can deactivate the virus. One last comment. The typical antiviral agents like acyclovir or Valtrex don't work, and so that's not part of the protocol. Those antivirals do not work on reactivated Epstein-Barr virus, but things like ivermectin plus some other newer things you probably haven't heard of do have an effect, and we do have a written protocol at this time. So I do want to continue to beat the drum for testing and to realize that when you have a serious disease like adhesive arachnoiditis and you're getting worse, you need the test because you're going to need to try to control the virus if you do have a reactivated virus. Now, I'm going to kind of segue into something that's a little related to this. There's another development out here in the world of pain, and that is people are going down to get MRIs, and they go down and they've got symptoms, and they've got symptoms of bad, severe back pain, radiating, might be pain on sitting. They've got bugs crawling on their legs, burning feet. But they have the MRI, and the radiologist comes back and says, no adhesive arachnoiditis. And then you take it to your neurologist, and your neurologist lab will say, you don't have adhesive arachnoiditis. Then you ask the doctor, well, what do I have? And he says, I don't know, but you don't have adhesive arachnoiditis. Well, let me tell you what we're finding out today. The good news is that people are actually going down to get the MRIs much earlier than they used to. Now, you understand the MRI and the testing today, and everybody needs to kind of understand this. You need to understand one thing. Adhesive arachnoiditis is when you get an inflammation in the cauda equina. Those are the nerve roots hanging down in your spinal canal, and inflammation at the same time in the arachnoid membrane, which is the inner lining of the spinal canal. And now, once you get inflammation in both of them, they'll glue together and form a mass. That's adhesive arachnoiditis. But what you need to know is this. You can have inflammation in just the cauda equina or just the arachnoid membrane, and you go down to get an MRI, and that MRI is going to be read normal, okay? Now you've got the symptoms and you've got the inflammation, but you're not going to get a diagnosis because what you've done, in effect, is have the MRI taken before the full-blown disease has had time to develop. That's the good news. Why? You're far better off getting a diagnosis before you get adhesive arachnoiditis, because that's when it gets difficult to control. But if you can catch it at the earlier stage, then that's great. Now here's the problem with it. The radiologists today do not read out these preliminary precursor diseases, okay? Now, and they're not used to. But anyway, I am here to tell you that I will use the term chronic cauda equina inflammatory disorder, and I'll use the term non-adhesive or arachnoiditis. Now, when I look at these MRIs, because I do it every day, I can see subtle changes in the cauda equina or in the arachnoid membrane, and I can pretty well tell that the symptoms are being caused by this. But you're not going to get normal radiologists or normal medical practice today to recognize these conditions. And so what do you do about it? Well, first off, what would be nice when you have all the symptoms and somebody says you don't have adhesive arachnoiditis, it would be nice if you could get a cytokine panel test. But cytokine panel test where you get all the leukotrienes and you get the tumor necrosis factors and those things. It's a very expensive test and it's hard to get it ordered. And so I'm not saying it's impossible to get your cytokines measured, but it's difficult. In fact, it's hard for a doctor to even fill out the form, let me assure you. Okay, so it's hard to get those tests done. It would be nice if you could, because if they are elevated, it kind of confirms, yes, you've got inflammation in your arachnoid or in your cauda equina, but you don't have adhesive arachnoiditis yet. You will get it sooner or later if you don't step in and do something, however. Now, the other thing that I do, and it's kind of to me, it's one of the greatest tests going. If a doctor will give you a 6-day mid-roll dose pack, it's the best diagnostic test for inflammation of the spinal canal there is. Because if you get better with that 6-day mid-roll dose pack, you've just made a diagnosis that you've got inflammation in the spinal canal and you need treated or you need inflammation suppressed. So I like a 6-day mid-roll dose pack, not only for therapy, but also for diagnosis. Let me just summarize this discussion this way. We probably should start using a term called spinal canal inflammatory disease, because that inflammation isn't just causing adhesive arachnoiditis. Chances are, before you get adhesive arachnoiditis, you're going to have inflammation in your discs, in your ligamentum flavum. You may have Tarloff cyst, and you're going to have these other inflammatory conditions. In other words, today, at least when I look at an MRI, I can see the inflammation in all these different tissues. And so in some respects, we should really be looking at this in a little broader context, thinking in terms of spinal canal inflammatory disease and treating that, because this way we can prevent a lot of cases of adhesive arachnoiditis and a lot of suffering and a lot of pain. So anyway, this is kind of where we're at research-wise on looking at MRIs, but I do want people to know that the good news is we can diagnose these other conditions before you get AA and do something about it. The bad news is the radiology and medical profession is not ready to diagnose this at this point in time. So anyway, with that, we're going to try to move on. I'm very, very excited to introduce our guest tonight. Her name is Melissa Wardlaw, and she's got a journey of her own to talk about, but she's also in that journey learned a great deal about how pain works, how the body works, and she's now sort of formed her own, might say, therapeutic company, if you want to call it that. But anyway, she's got a story to tell and some help to give. So anyway, Melissa, are you on?
Hi, Dr. Tennant.
How are you doing? Good to meet you.
Thank you. Nice
Let's
to
start
be
off
here.
with a couple of basics. So where do you live, first off?
Yes, sir. I'm in Atlanta, Georgia.
Atlanta, Georgia. And tell us a little bit about yourself. Married, family, kids, education. Tell us about who you are.
Well, I am divorced and I'm an MBA, former business consultant, executive, and now I help people in peer counseling and advocacy. I don't have a company, but I do run a support group and do advocacy and write articles and things of that nature to kind of get the word out. But I am still disabled. I am still dealing with chronic illness and pain 24/7 and a whole list like most of y'all here, I'm sure. But
Yes.
But
Well,
yeah.
the reason I had you come on the show is that you've related to me a lot of the things that you've done, and I was very impressed because I like to I want anybody on this show who's figured out how to beat this to some extent, and much less if you're willing to share it like you've been. You go ahead and tell us about your own journey, how you became ill, and we'll let you kind of take it from there because I don't want to embarrass anybody with my questions. But
Yes, sir.
you could start from the beginning. What happened to you? How'd you get in this mess? In other
Well,
words,
to make a
why are
long
you
story,
unfortunate enough to be here?
it's a very long medical journey, as I'm sure most of you have the same experiences. But back in 2002, I had lower back and neck pain. Still do have that, by the way, chronic. Didn't know what caused it, but I was just, a workaholic and decided to finally get it addressed and went for epidural steroid injections. And they were done at the same time, which I understand is not the way to be done. But nevertheless, something went wrong with the cervical epidural, and the needle ended up transecting all the way through my spinal cord, causing a spinal cord injury. And that was later confirmed by multiple MRIs. And so we didn't know what had happened for a while, but I was severely in pain to the point where I couldn't even, take a shower by myself. I couldn't let water run over my right arm, right hand, and had to lay down. It was very positional. I had a spinal headache. I could barely walk. I was not paralyzed, thank God. But anyway, so as time goes on, finally figured out it was CRPS. And as the journey went on, my pain got much worse instead of better. And so for let's fast forward about 10 years, the desperation ensued, as I'm sure most of you all, understand that pain desperation where, you pretty much want to jump off a bridge and want to make it go away and get back to your old life. I had a very, full life at the time and was at the top of my professional game and was about to get married. And so it was not the right time for that to happen, but it did. And so long story short, I went through a whole host of invasive treatments and medication after medication after trial, and ended up getting worse and not better until about a decade later of being homebound, bedbound, not being able to drive, not being able to work. And about 10, 12 years later, finally just from a fluke, ended up doing hormone replacement therapy. This is after, I'm very condensing everything here for the sake of brevity, but had gone through some other hormone related cortisol stuff, testing. My cortisol levels were shot, my adrenals were shot from what I understand. But long story short, I went on hormone replacement therapy and it was a miracle. It was absolutely a miracle. And it was a breakthrough for me. Instantaneously, I was better. I was better in terms of my pain and symptoms. And what I have later found out, it allowed my body to kind of come back into balance because all the treatments I had been doing, the medications I had been taking, all the pain I had been suffering, and the mental on top of that it was causing had caused my body to just go out of balance and completely my general health was in a tailspin. And so the hormones had just gone out of whack as well. And so by getting my hormone levels back to basics and then treating my general health and then alongside that with my mental health, because the other kind of 50% of that with the hormones was figuring out that I'm not going to be able to beat this situation, so I have to join it. And so I had to learn how to accept this, and I had to learn how to manage it instead of try and fix it. And that's a huge thing, in my opinion, for chronic illness and pain, is that you can't fix it. You know, sometimes I don't have adhesive arachnoiditis. I have CRPS. I have a whole host of other things that I could, you know, I won't go through the list, but as I'm
Melissa, I want to step right in here for just a minute.
Yes, sir.
You may have CRPS, but you fundamentally have a spinal cord injury. That's where you
Yes.
started,
Yes.
and you still have it, as you pointed out.
Oh, yeah.
Got it. Okay, now.
And I have degenerative disc, and I've had a lumbar fusion, and on
I
and
want
on.
to go back to your hormones, because that's what attracted me to me.
Yes, sir.
I got attracted.
That's how I found you.
The hormones. Yeah. Anyway, did you take a blood test to find out about what hormones you needed, or how did you? Because I want to know about which hormones you took.
Well, it was a fluke, how I found, it's a very long story. I don't know how we have the time for it, but I actually thought I was having fibroids. I ended up later having fibroids and endometriosis. I still have those, but anyway, they ended up putting me back on the birth control pill. So they didn't do initial testing that time when they put me back on the birth control pill. Previously, I had done bioidentical hormones. I had done HGH, not even knowing what it was, really, not understanding. I had gone to an endocrinologist. I had gone to, you know, functional medicine doctors. I mean, you name it. I've tried it. And those things didn't happen to work. I don't know. I don't think they really did much testing because they would have seen, well, they must have, because he said my adrenals were shot. That's the quote. But whatever he did for me didn't seem to work as far as those particular hormones, or the bioidenticals didn't work. And the HGH didn't work for me. But once I was put on just basic birth control, that was what I needed. So it was a combination, you know, it's a combination. I'm still on it, or else I wouldn't be able to function. You know, of the estrogen and the testosterone and the progesterone.
Did anybody ever tell you why the birth control pill works?
Well, because the chronic pain, the medications, those all wipe you out. They wipe out your system. Right. Go ahead.
Anyway, reason why I want to focus on this for a couple of minutes.
Sure.
It is not well appreciated, and as a matter of fact,
100%.
I'm trying to research this myself, but we know one thing. The spinal cord itself produces what amounts to a birth control pill. Okay, the spinal cord itself produces progesterone, estrogen, testosterone, and a birth control pill actually contains progesterone. Okay, progesterone may be the hormone that we are simply not even addressing adequately enough. But I can tell you that I could show you a litany of studies showing that rats that have their spinal cord injured, if they take progesterone, DHEA, pregnenolone, estrogen, the spinal cord heals. Okay, so frankly, if you want to give out a message tonight, anybody who's got a spinal cord disease or injury, okay, call it what you want, whether it's arachnoiditis, CRPS, or multiple sclerosis, call it what you want. But if you've got a pain that relates to your spinal cord, you should be taking some of these hormones, because that's the good Lord's natural way of healing the spinal cord. And so pain-wise, yes. The other thing that's not appreciated, the receptors in the brain, they partner with these hormones to be effective. And even your natural endorphins won't work very well, much less any opioid doesn't work very well if you've got a hormone deficiency. The bottom line is, and I go along with this, I just interviewed somebody this last week who's taking about 4 different hormones and about 4 different peptides, severe case of adhesive arachnoiditis, no opioids. The pain is controlled. We think that's the way with the future. That's why you're on here tonight. You're a good poster child for what you're saying. Spinal cord injury, hormones, you're doing better. Now that I've interrupted you, go ahead, start from there. Okay, once you realize you got to manage it yourself, take it from there. What'd you do next?
Well, I'll tell you what, that is really my message, honestly, was to go back and kind of redo, okay, what am I not addressing as far as my general health? Let me go back to the basics, because I had been neglecting all of my general health and my mental health. And, I was suicidal, honestly, and I've written an article about this as well, for 10, 12 years. I wanted to jump off a bridge, and it wasn't depression necessarily. It was the pain. It was the it was the torture of the pain. Of not being able to get out of this pain every day, 24/7. I couldn't sleep. I couldn't, it was just torture. And so, I had to find a way to fix this. So all of that combined, I had to go back to basics and figure out, let me balance my system so that some of these treatments for the chronic issues can start working. So it was that when I realized that, okay, I can't fix this. I spent so many years trying to fix it and get back. The only option for me was to fix it or kill myself. That was it. Those were my 2 options. And that, neither one of those were going to work. So once I finally broke through to realize, okay, well, I've got to find another way. That's when I started accepting it and going through kind of, as we all probably, know or don't know, there's, the stages of grief that apply to chronic pain and chronic illness as well. And I think it's very important to recognize that and to experience that. And it's not linear. You don't go through, each stage, one by one. You can go back in and out of some of them. And there's always usually a situational depression and anxiety that goes along with chronic pain and illness that's caused by the chronic pain and illness, not vice versa. So, it's important to get your general health balanced as well as your mental health balance. So then you can address these chronic issues, the chronic pain and chronic illness that, is battling. So once I was able to kind of address those and, see some improvement, then I was able to, these things that weren't working before per se, were able to start working. And I was slowing down and my nervous system was able to be more calm. I wasn't so stressed out. And then I was able to see, okay, well, what's working and what's not, and take it more on a step-by-step approach and not be so desperate, And so once I halted that desperation, then I was able to kind of take one thing at a time and see, okay, well, I don't need to have brain surgery, for this to kind of rev up my nervous system even more, and make everything worse. I just need to do some life strategies. I need to do some meditation. I need to do some more supplements. I need to do some, different medications, maybe some Botox, so these are the things that, have worked much, much, much better for me. And that's when I found you and with the hormones. And that's kind of what my message is today. You need to really, look at everything, take a slow approach, take a very stress-free approach, start out very natural and use the opioids if you need to with pain, because, they are necessary sometimes. And, a lot of doctors, of course, don't agree with that, but, I do. So And I tell everybody, it's a one size fits all. Not everything will work for each patient. Once you've met one patient that has CRPS or whatever your ailment is, you've met one person that has that. And so, you know, I try not to, whatever works for you, have at it. You know, I'm not going to judge for whatever works for each person, you know, because it's different. But for me, it's a multimodal approach that works for me. So it's a combination of things and that I'm constantly doing. And I have a couple of them right here in front of me. You know, I have my pain spray, and I've got my my medication, and I've got my my pillows, and I've got my water, and you know, all that. So my 10 unit.
A couple of things.
What's that?
I know that you have your own online teaching and what have you.
Yeah, support group. Mm-hmm.
Right. First off, let's make sure, how does somebody get a hold of you and your online support group?
Yes, I have my email address is underneath my name right there. I do peer counseling and advocacy, and I don't charge anybody. It's just something that wasn't available when I was first diagnosed, and so I wish that it was there, and wish there was somebody to talk to and kind of guide me. But I help people and fellow patients, peers who have chronic pain, chronic illness, CRPS. Newly diagnosed, and people who just need support, and I'm there to kind of, just guide you through it. And my support group is local. It is in the Metro Atlanta area. We do meet in person, and we have an online, Facebook group as well, obviously, where people share their thoughts and resources and support, and it helps people too. So, but yeah, I'm here if anybody, wants a phone call or an email, then please, reach out to me. That's what I do. That's my purpose these days. I'm still in pain 24/7, so I'm not cured. There is no cure.
Okay.
As
Couple of
Dr.
things.
Tennant, I'm sorry?
You had your water bottle and your medicines and what have you.
Yes.
Do you mind sharing what do you have to do now in the way of any, knowing you?
Yeah, well, it's a combination, Dr. Tennant. I mean, it's, I just started on PEA, by the way, and that's how I reached out to you initially. I just started PEA about 4 days ago, so we'll see how that's going. I know it can take about 5 weeks or even a couple of months to work, so we'll see how that goes. I take a different cocktail of medications, and I have supplements that I take, which things are I've been on that cocktail, so to speak, for many years, and it seemed to, as you say, it's controlled pain versus uncontrolled pain. And that was what I didn't understand. I had, when I was in the throes of this, back in the beginning, I had a doctor tell me, there's a difference between suffering with pain and living with pain. And I didn't understand what that meant, and it basically means that you have to deal with it. You have this pain, but you don't have to suffer. You don't have to wallow in it day by day. It's like, I can't, there's not a lot I can do. I'm not, looks can be deceiving, but makeup and hair doesn't cure. But I always say that with invisible illnesses. But basically, if I need to go somewhere out to dinner, I have to fully plan it. Something even like this, it is a fully planned process. I have to rest beforehand and plan it out, prep beforehand. And after this is done, I will go immediately lay down on my heating pad, and I will turn off everything, have the quiet, and have some distraction with the TV or something of that nature. So it's a very life strategy type process for me to have to manage my life in order to do things I want to do, such as my volunteering and my work that I do, and even my social life, barely what it is. So, those types of things I have to really plan out, but it's worth it in the end because, psychologically that helps your pain. And then, when you're out and about, that helps. And it's a vicious cycle. Everything helps.
Well, let me just say, not only congratulations, but also I want to thank you for coming on the show and sharing. And I hope that people, because of this show, do contact me. You've got a message to relay, and I believe what you're saying. I'm with you 100%. I think the way you've gone about this is, I'd like to bottle it and sell it, but keep it up on what you're doing. Okay?
Well, it's because of you, and I tell everybody about you, and so I appreciate what you do, and and the message you put and all the
We're
new tricks that you give us. So
Yeah, no, again, I think the hormones are very underrated. A lot of
very
the
much so.
herbal things like PEA, a lot of the exercises, the diets.
Pilates, that's what I
Pilates
swear
is
by.
terrific, terrific. I like Pilates, yeah.
Mhm.
Very good. Okay, good luck, and frankly, I want you back here in a couple of months to give us
Sure.
a progress report, okay?
Sure, Dr. Tennant.
All right, well, thank you so much.
Thank you.
Actually, while you're still here, Dr. Ibsen, Dr. Guest, Dr. Clement, any of you want to ask her a question?
I would, if I may.
Sure.
You mentioned mostly sex hormones with the hormone therapy you got. Did anybody look at your thyroid? And are you
Oh
taking
yeah. My
supplements?
thyroid was not really affected. My thyroid was for the most part okay. It was mainly my cortisol levels, which they're still, I mean, they've been up and down, believe it or not. It's hard to pinpoint, why they're not one way or the other over the years. I'm not sure why that is. Maybe you guys have some direction on that.
I have thoughts.
Yeah. Well, by the way, one thing I do want to say why Dr. Tennant, I think it is so important is, not a lot of doctors understand this. There's not really a lot of specialists that understand the link between hormones and chronic pain, chronic illness. I have a really good endocrinologist right now that somewhat understands it, but and my doctor is a believer in you and my pain doctor. So but it's hard to come by that they understand and can spend the time, to really guide you with understanding and getting these right tools. So anyway, sorry to interrupt you, doctor.
Oh, yeah, no problem. I was just kind of surprised that your thyroid was in the normal range.
Believe it
Are
or
you
not,
doing
yeah.
like the periodic medroxyprogesterone or dexamethasone to help stimulate the cortisols or get them back up?
I know that at one point they did a very strange test where it made me pass out.
Hmm.
And then he proceeded to do the HGH, the human growth hormone.
Okay.
And I didn't really get a lot from that. So I don't know if that tells you anything. Does that answer your question? No, there are a lot of these tests. It was a long time ago, and so I don't really remember exactly what they did.
Yeah. And I'm kind of surprised the bioidenticals didn't work. I'm wondering if they were just too conservative in the dosing and didn't
I
get
wonder.
in there
I
to do the
do.
job.
Yeah. It was a long time ago, and I don't know if I was still, if it was still too early, if I just needed to get on something that would, I don't know, maybe it was getting the right combination. I'm not sure, but no, they didn't do anything for me, unfortunately. And I was diagnosed with PCOS along that way in the process as well. So I've always had a problem with my hormones.
Lucky you.
Yeah.
Okay, thank you.
Thank you.
Mark, Norman, either one of you want to ask her a question?
I just wanted to, what I enjoy about this conversation is that the complexity and the diversity in treating pain and in terms of medications that are being used and the conversation that the young lady makes says there's no one size. There's each of us have an individual dynamic. Our species, we are individually dynamic species, and we respond. One may respond to one form of treatment, and one may respond to another. But I'm curious to know in the process, and of course, as this deals with the pharmacy and stuff, have you had the displeasure of dealing with going to your pharmacy and getting profiled or being said that, well, you don't need this without anyone inquiring? Have you had that difficulty at all in discussion or so?
Of getting at the pharmacy, getting
profiled as
just like being
at the
discriminated against.
counter, right at the pharmacy counter, being saying that you're taking to. Have you had that experience?
I would say it's been more with doctors. I hate to say that, but the pharmacy's been pretty. I've had the same pharmacy for 20 years, So
That's great.
yeah, and I've made sure to do that, you know, because I know what's out there, because I talk to people every week who deal with it. So but it's been more new doctors. So, dare I say younger doctors? You know, I don't know if that's a stereotype.
I dare you.
What's that?
Mm.
I dare you.
Yeah, I know. It's, I don't know. Ugh. Well, hey, you know, I could go on and on about that, but you know, yeah, yeah, it's been a struggle, you know, it has, but luckily I've been with my doctor, my pain management physician. I have two. I have an interventional and I have a quarterback pain management. I've been with 22 years, and he's been with me every step of the way, and luckily he's one of the good ones, and understands and is compassionate, you know. So I've been extremely lucky in that regard. So, but not everybody's that lucky. So, but going to a new specialist or somebody that, you know, may not understand and may look, of course, I don't always have makeup and hair on, but, you know, somebody will look at me and say, huh, you know, what's wrong with you, kind of thing. So people don't understand. A lot of, you know, friends don't understand, you know. So yeah, I think I went on a little bit more about your question, but hopefully that answers
That's
it.
okay.
Yeah, that's
Thank
all
you
right.
so much.
Well,
Yeah,
thank you so very much again, Melissa. You've been great to have. We'll have you back, and keep up the great work, and also keep teaching. Okay,
Thank you. You too.
my
Thank
pleasure.
you.
We need to
Thank you.
segue now off into the last part of the program. Mark, I want to start with you. We talked earlier today that there has been a study out and a lot of comments lately about how the misuse and the fraudulent use of the terms central sensitization and hyperalgesia. And a lot of people are being denied care because they're being told they have these conditions. Mark, you want to start off because this is really an ugly subject, to be honest about it, to where the terms of a false hoax medical condition is being drummed up as an excuse not to treat people. Anyway, Mark, I'll let you start it off, and then I want to call on Norm and Scott as to get their comments on the use and misuse of the term central sensitization and hyperalgesia. Take it away, Mark.
Thank you, Dr. Tennant. I'm going to tell a story. This is like 25 years ago. I was working a night shift in the ER, and I was due to get off at 7 a.m. And around 5:30, I felt a little twinge right at the tip of my penis, and I thought, that's weird. I didn't put that where it doesn't belong. So what's going on? So then the pain increased, and it went into my flank, and I started passing blood. And I realized I was having a kidney stone. The morning doctor was not due to arrive till 7, and by this time it's like 6:15 or so. So he's already in the shower and is on his way there, and I have no options but be in agony. So I had the nurses put an IV in me to maybe hydrate me, and it was a slow night in the ER, so I had a couple patients that were already tucked away. And then the pain went to a 10 or a 12. And by the time the next doctor came on, I was writhing in agony. And it took 30 milligrams of morphine to get my pain relieved. And I've had 4 or 5 kidney stones since, and it's taken maybe 2 Percocet over a month's period of time. So part of it was not knowing. Part of it is the demand that I have in my job to be fully present. Like I couldn't take any morphine while I'm on the job. Even though I was incapacitated, there was nobody else to do the job. So I'm just writhing until the next doctor comes in. And that is my experience of um, uh, hyperalgesia. Um, Pain from the same same kind of kidney stone resulted in needing 30 milligrams of morphine or 2 Percocet over 30 days. So it all depends on context. And this whole thing about hyperalgesia is not researched. You hardly could research it at all anyway, because pain is subjective and you can't measure it in a way that you could be reliable in a double-blind placebo-controlled study. But my patients, and they're going through it right now, there's a shortage of hydromorphone, and I have some people who are hyperalgesic right now, and they're scrambling for where they're going to get their medication. And the thing is, I used to tell patients in the ER, I have more medicine than you have pain. And immediately their pain level dropped by 50%, just knowing that we're going to treat their pain. And I can't do that anymore. A, I'm not working in the ER, and B, there's a shortage, and you can't promise relief to people who need it. And so that raises anxiety and conflict and trauma and our adverse childhood events. And an adverse childhood event can be anything from being molested to not being invited to your best friend's birthday party. They're both just as serious to a 5-year-old. So all of us have adverse childhood events, and I agree with you that it's bogus to talk about hyperalgesia. It's also bogus, and Claudia has a couple of videos about this recently, about doctors saying, well, morphine causes pain. No, it doesn't, and that's all BS. So we have to do our best to speak truth to some of this false information out there. As far as central sensitization goes, I sometimes give a patient a model that, yeah, your pain has a pathway in your brain, and it's worn that pathway in, and we got to interrupt it. And maybe that's an inaccurate way of talking about it, but I think that's not as controversial as the totally bogus idea that that hyperalgesia actually occurs, and it's not caused by an opiate.
Yeah, let me go on. Scott, are you there? I'd like to get your take on central sensitization and hyperalgesia. What do you have to say?
I am here. Central sensitization, a decade or so ago, when we were going to Pain Week and all the other national conventions or conferences so many times, they were pushing that and something called wind up, which I think they were trying to call the same thing. And I don't think they ever did really explain it well. Certainly not the way we are explaining centralized pain now as being the inflammation of the glial cells and the superhighway and the down regulation side. Hyperalgesia, there's a lot of people that go back and forth on it. I do believe it can occur. When I was working with you, I did have one patient who had, as we increased the dose, her pain got worse. So we said, okay, you may be that one patient. And so we dropped the dose down a little bit and she improved. I think a lot of opiophobes really like to push that hyperalgesia thing way too far. It's certainly not as common as they like to think it is, but it does happen. I've seen it.
Yeah. Now, what about people who are being denied treatment because they're being told they have central sensitization?
That's like you said, we've got this central sensitization, this term that doesn't have any definition or any meaning or any pathology behind it that we do with centralized pain. So I think these are people that are, they're prescribers and physicians who are just, they don't know what it is. So they're just throwing that at it to get rid of the patient.
Mm-hmm. Yeah, I think basically no brain, no pain.
Yeah.
So
no headaches.
Yeah. Okay. So it's central. I don't care. It hurts.
Yeah.
And we have to treat it. And when you treat it, people get out of bed, they go to work, they love their grandchildren, and they participate in Thanksgiving. As long as they don't talk about politics. So it's like it doesn't matter to me. It's not a diagnosis that makes a difference. And you know what makes a difference? And Melissa showed us this today, is you just don't give up. You keep trying stuff because the scientific model is still active. One doctor, one patient in a conversation trying stuff. You come up with a hypothesis, you test the hypothesis, and then you resolve your hypothesis or you readjust it. That's the scientific model. It's been present since the Renaissance, and we need to go back to it and say, look, if a birth control pill suddenly helps your pain, then you're getting more of it, as far as I'm concerned. And I don't know how you find these things out other than trial and error. And patients don't like to be a guinea pig. Well, here's the thing about a guinea pig. The guinea pig is not in charge of the experiment. The patient is in charge of their care. So you're running the experiment if you're collaborating with your doctor and you say, I'd like to try this. And if you come to me and say, I'd like to try this, and if it's not strychnine or some other thing that might be fatal, then I'm going to say yes to you, because yes means you're involved in trying this. And when you're involved in trying something, you're going to make it work.
Yeah,
Very good.
So let's let people collaborate and make it work. Yeah, thanks.
We just have a few minutes left. Norm, are you there? What you get to think about central sensitization?
Well, here's the thing that I have come across, over my experience in pain. These definitions change from year to year, and I was looking at this word hyperalgesia, and what I found was we have this we've acronized it to OIH, opioid induced hyperalgesia. And again, where's the science behind these sort of things? I think Mark asked, where's the science? Where's the science? I mean, sure, there are conditions where these things occur. But again, when we want to get on these tirades or so that narcotic analgesics are working, we then have all these inventions of OUD and OIH and those sort of things to support our flawed analysis and denying people proper pain care. And what Mark has pointed out, and the young lady says, medicine has been all about that. We've always experimented and used novel approaches in terms of getting to solving various disease and disease states. Potter Stewart talks about this in the decision, and one of the, I think it was the Moore decisions, is, isn't it true that those physicians that who have used a novel approach, something that's outside their field, that's how medicine has operated, and more or less that is and has led to some dynamic discoveries and some dynamic innovations. I mean, this is an art. It's an art as well as it is a science. And the fact that we want to come to these these hardcore default such as the OUD and OID, and then have these misinformed pharmacists or PharmDs, physician wannabes that do not understand the complexity or on this tirade about narcotic analgesics and those sort of things is a danger to our profession. And again, if the patient needs it, if they get relief from it, if it works, we may not be able to explain why it works, but it does. And so that's what I'm looking at. That's mine.
Thank you very much, Norm. We're ready to close out here, and we've had a real good session. Let me just summarize real quickly that the term central sensitization and even hyperalgesia are not medical conditions that can be quantified, diagnosed, and standardized. And they're being used occasionally by physicians who are, frankly, probably fraudulent or really inappropriate by saying somebody should have their dosage reduced or opioids denied because they have central sensitization or hyperalgesia. Anybody who hears that needs to turn and go the other way, because that's an unscientific, inhumane response to these terms. They are not legitimate medical conditions, and they should never be used as a reason to deny treatment much or reduce a dosage. With that, again, thank you, Melissa, for being here, and everyone. We've had a great show, and we'll be back next week. We'll see you then. Good night.
Thank you so much.
Good
We've had
night,
a great
everyone.
show tonight.
Good
We
night,
really
everyone.
appreciate you. It's been a
Beautiful.
wonderful show. We hope everybody took
Yes,
notes
it
and hope to see you
was.
again next week. Thank you
Thank
very much.
you.
Good night.
Thank you.
Thanks, everybody.
God bless you all.
Jamie, did that letter,
Sure.
that article help you?
That was a wonderful article. You're doing such a great
Yes,
job.
it was
And
so
that is on
good.
youarewithinthenorms.com. Everybody check it out. Thanks so much. Don't forget about arachnoiditishope.com as well. That's a really big one. And we do take the bulletins from those. I wanted to let you all know quickly. I'll be letting Dr. Tennant know this in a little bit, but I wanted to tell you something. We've got a comment from David Green, and he says, my primary care doctor finally increased the potency of opioid medication. I'm no longer in the ER every week. Thank you to Doc Talks for educating me and giving me hope. Without Dr. Tennant, I wouldn't be here. So thank you for everything you do.
Wow. That's awesome.
That's beautiful.
Thank you,
I
Jamie.
want you all to know
Thanks be to God.
you're part of that family.
Oh,
Exactly.
wow.
We thank you all so much
Thank
for being
you,
with
Lord.
us. Yes.
Thank you.
Thank you,
You
Jamie, for
too.
and everyone for just helping us get together like this. This is what helps everybody being
Yes.
together.
That's
Oh,
right.
thank you. Thank you.
That's right. Thank
Yeah.
you,
Thanks,
Miss Donna. We're happy to be here with you.
Oh,
Yeah.
God bless you. God bless
God
you.
bless you too.
Good
Feel
night.
better soon, Jamie.
Yes,
Thank
please,
you. I
Jamie.
will. And you
Love you
too.
guys.
Thank
I love
you.
you all very,
Love
very
you
much.
guys. Love you
Good
too.
to see you back,
Love you,
Kristen.
Donna.
Bye.
I'm so glad to see you here, Kristen. Yes. So glad to see everybody. Jacqueline, you keep kicking butt.
I am.
Jackie, you keep on.
I am. Love you.
Love you
Night,
too.
all.
Good
Good
night.
night.
Great
See you
job,
next
Thanks,
week.
Melissa.
Jamie.
Thank
See
you,
you next
Melissa.
week. Thank
Okay.
you all.
Bye-bye.
Bye-bye.
Good night.
Bye-bye.
I'll keep writing.
Keep writing, Doc Norm. You're doing a great job. Great
Thank
job.
you.
Yes,
Thank you.
beautiful job. Thank you, Norm.
Really.
Thank you. Thank you very much.
Thank you.
Thank you so much, Norman. Good work.
Thank you very much.
Good night,
Good
y'all.
night. Love y'all.